Hello. In this episode, we discuss pulmonary hypertension and cor pulmonale. Now, what is the definition of pulmonary hypertension? Either a resting systolic pulmonary artery pressure greater than 30 millimeter mercury or a mean pulmonary arterial pressure of greater than 22 or, based on some references, greater than 25 millimeter mercury. What are the subtypes of pulmonary hypertension? The primary or idiopathic type is also referred to as pulmonary arterial hypertension. However, the word idiopathic or primary does not mean that we do not have associated conditions. So idiopathic is at least one of the, let's call it, subtypes of primary pulmonary arterial hypertension. So when we use the word primary, we mean the very initial event in the pathogenesis of the disease involves endothelial hyperplasia or smooth muscle overproliferation. There are, however, other diseases or disorders who can increase the pressure in the pulmonary arterial system, but through different mechanisms. So this is exactly the conceptual difference. So what are the major causes of group 1 or primary idiopathic or pulmonary arterial hypertension? The emphasis is the word arterial. Well, one form is the hereditary form due to an autosomal dominant inactivating mutation of BMPR2. What is this thing? Bone morphogenetic protein receptor 2 is part of TGF-beta signaling pathway, and its function as a pro-apoptotic mediator is prevention of smooth muscle proliferation. So it is logical to see if it loses its function, we will have unregulated smooth muscle and endothelial proliferation. You remember what is the pathologic feature of such change? Medial hypertrophy, intimal hyperplasia, and ultimately formation of a capillary tuft within the vessel lumen that's referred to as what? The plexiform lesion. Okay. Are there other conditions associated with group 1 or primary idiopathic or arterial type pulmonary hypertension? Pulmonary arterial hypertension also could be seen in association with HIV infection, portal hypertension, certain drugs and toxins, such as what? Fenfluramine is the top of the list. And two very important conditions that require differential diagnosis with other groups that we will discuss. One is left to right congenital shunts, that is systemic to pulmonary, three-letter congenital heart diseases such as VSD, ASD, or PDA. And the other are certain connective tissue diseases such as rheumatoid arthritis, SLE, and systemic sclerosis. Why these two are important differential diagnosis of other groups? Because we will later on mention that group 2 includes pulmonary hypertension secondary to left-sided heart disease. I want us not to confuse presence of left to right shunts with that group 2. Presence of left to right shunts causes the same pathologic changes that we just mentioned in endothelial hyperplasia as the initial event causing pulmonary arterial hypertension group 1. While left-sided heart failure or left-sided valvular lesions would result in pulmonary hypertension through other mechanisms, and they belong to group 2. Likewise, connective tissue diseases such as rheumatoid arthritis and systemic sclerosis and SLE could cause lung fibrosis and interstitial lung disease. And interstitial lung disease, similar to other causes of lung disease, can cause chronic hypoxemia, and through vasoconstriction cause pulmonary arterial hypertension. These belong to group 3 pulmonary hypertension. However, same connective tissue diseases could also primarily and directly cause pulmonary arterial, endothelial, and smooth muscle changes, and those are then categorized as pulmonary arterial hypertension. How we distinguish that? Well, if our pulmonary function test or chest x-ray or high-resolution CT shows any indication of interstitial lung disease and lung fibrosis, we are dealing with category 3. But if we have a patient with SLE, rheumatoid arthritis, and his lungs are clear, yet he has pulmonary hypertension, then we say that is group 1 or the primary type pulmonary hypertension, that the pathology primarily has affected the vessel wall. The pathology has not affected something else, such as pulmonary arterial vasoconstriction, and during the time secondarily we have vessel wall changes causing pulmonary hypertension. So be very careful about that. Why is it important from a clinical perspective to know all these groups? Because the management differs. Okay, so as far we have discussed group 1, 2, and 3. Group 1 is this idiopathic condition or the autosomal dominant heritable one or HIV associated, portal hypertension associated, and the connective tissue disease association. Then the drugs or toxin I mentioned, fenfluramine. And then we have discussed group 2, and those are the left-sided heart diseases. Don't confuse them with the left-to-right shunts as the cause of primary type. Then we discussed any type of lung disease, such as obstructive lung disease, restrictive and interstitial lung disease, hypoxemia, obstructive sleep apnea. These all belong to category 3, again, conditions of lung disease or hypoxemia. Then category 4 is chronic pulmonary embolism. That is that, and category 5 are all other conditions that don't belong to any of the previous categories. Examples of category 5 or miscellaneous category include sarcoidosis and chronic myeloproliferative disorders. Now, what are the symptoms of pulmonary hypertension? Regardless of the category or group that we discussed, pulmonary hypertension manifests with exertional dyspnea, which is usually progressive and associated with fatigue. There could be exertional hypoxemia as well as exertional syncope. What are the physical exam findings? We have loud P2, left parasternal lift due to right ventricular heave, and on the advanced stages we will have the signs symptoms of right-sided heart failure. We will discuss them on Cor Pulmonale. Are there any clinical findings that can hint in favor of hypoxia? Chronic hypoxia could manifest as clubbing, while the acute ones, such as exertional ones, could manifest with plethora or cyanosis. Put it simple, the symptoms include exertional symptoms, symptoms of the underlying condition, and in advanced stages, symptoms of right-sided heart failure. Okay, now how do we diagnose pulmonary hypertension in a patient who has these symptoms and underlying risk factors? We could have two approaches for diagnosis, and I want you to apply both of these in parallel. One is just the very best first set of tests followed by the gold standard confirmatory test, and the second one is etiologic assessment. So the set of our first tests include chest x-ray, ECG, and echo. But if you are asked what is the very best one of the first tests to order, that would be echo. Echo would show pulmonary arterial hypertension as well as providing assessment of right ventricular function. Regardless of the underlying etiologies we discussed, if the patient has any type of pulmonary hypertension, what you expect to see on chest x-ray, we see enlargement of the proximal or central pulmonary artery and branches, plus pruning of distal branches. What is this pruning? The rapid tapering of the more distal vessels. What are the ECG findings? Those of right ventricular hypertrophy, including right axis deviation. You have overall negative QRS complex or heart axis on lead 1, but you have positive QRX on leads 2 and AVF. That's definition of right axis deviation. Plus the criteria for right ventricular hypertrophy. What are they? Do you remember? The ratio of R to S in lead V1 is greater than 1. That's also referred to as the reversal of R progression, or simply R in V1 is taller than 7 millimeters. The other important finding in ECG is right ventricular strain pattern. Can you describe that? That's presence of repolarization abnormalities on right-sided leads, mainly leads V1 to V3, and repolarization abnormalities include ST depression, but most importantly, T inversion. That's a T wave whose axis is opposite that of the predominant axis of QRS. If this pattern is seen in right-sided leads, V1 to V3, this is called right strain pattern. It's seen in pulmonary hypertension and a couple other conditions such as pulmonary embolism, cor pulmonale, etc. Okay, so these are the initial tests. The best first test is echo, but what is the very best or confirmatory test? That is right ventricular catheterization. The reason is it provides exact measurement of pulmonary arterial pressure. Remember, the normal value is 8 to 20 millimeter mercury, and the diagnosis is usually established if the value is greater than 25 for the mean value. Next step is etiologic assessment. The assessment of the underlying etiology requires understanding of the groups that I mentioned and the tests associated with the condition. So if a patient has the signs and symptoms of pulmonary hypertension and let's say has had a history of IVD abuse or unprotected high-risk sexual behavior, you are thinking about HIV and you order HIV testing. Next case is a patient who has history of systemic sclerosis or any of the connective tissue diseases. You may want to order chest x-ray or CT to see if we have any indication of interstitial lung disease. The first test is always chest x-ray. The best next step would be high resolution CT. Or you may want to order the immunologic serologic test in case there is no indication of group 3 lung involvement on those connective tissue diseases. So you order ANA for lupus, you order STL7T for systemic sclerosis, and you order tests for rheumatoid arthritis such as rheumatoid factor. If you, on the other side, have a patient with liver disease, you may want to order alkaline phosphatase and other liver function tests, such as you have an alcoholic, you are concerned about portal hypertension in association with group 1. Remember, the intracardiac shunts of left to right acyanotic congenital heart diseases could be evaluated by our first test, echo, again among the group 1. Echo would also diagnose the patient with left-sided heart failure or valvular disease. Remember, an important finding that could be reported on CAT is increased pulmonary capillary wedge pressure. If you hear this, what category of pulmonary hypertension we are dealing with? We are dealing with category 2 or left-sided disease. For the third category or lung disease, we order chest x-ray and if needed CT. For the category 4, which is chronic pulmonary embolism, we order ventilation perfusion scan. If none of these come back positive, again patient belongs to group 1, a subcategory of group 1 which is called idiopathic. Okay, now moving to the treatment for pulmonary hypertension. Remember, the treatment of group 1 requires targeting the endothelial changes, but the group 2, 3, 4, and 5 are treated by addressing the underlying etiology. Mention 5 groups of medications that could be used in group 1 or pulmonary arterial hypertension. We use prostanoids, which are prostaglandin analogs, especially that of prostacyclin, prostaglandin I2, including iloprost and epoprostenol, as well as a new drug, selexipag. Now, if you ask which one of these can improve survival, remember that is epoprostenol. If you are asked what's the important side effect, flushing. The second group are endothelin antagonists, such as bosentan. The other groups are phosphodiesterase 5 inhibitors, such as tadalafil, sildenafil, or activators of guanylate cyclase, such as riociguat. It's also shown that some patients benefit from calcium channel blockers, of course, dihydropyridine type. Remember, important warning for treatment with sildenafil, tadalafil. Yes, never co-administer them with nitrates. Risk of severe hypotension and syncope increases. Okay, now let's move to cor pulmonale. What is it? It is right ventricular failure, not due to left ventricular failure, but due to lung disease. Pulmonale means due to lung, cor means heart. Now, why we need to emphasize this definition? Because the most common cause of right ventricular failure is left ventricular failure. But in this condition, we are dealing with a pathology in which we have right ventricular failure, but it is not due to left ventricular failure, but most specifically is due to the lung disease. So you may consider the group 3 causes of pulmonary hypertension, all the lung diseases, as an underlying etiology. One thing I need to mention right here is an obese patient with snoring who has parasternal heave. What tests you order and how you treat this patient. This patient has contracted the complication of his obstructive sleep apnea, requires CPAP treatment and assessment of possible pulmonary hypertension complicating to cor pulmonale. Again, I emphasize that any of the conditions that can cause pulmonary hypertension and not just category 3 could also be associated with cor pulmonale. A challenging scenario is a patient with left-sided heart failure. If the patient contracts right-sided ventricular failure without symptoms of pulmonary hypertension, that is the common pathway from left to right failure. But if the patient, due to left-sided failure, contracts pulmonary hypertension and then has right-sided heart failure, that could still pass the definition of cor pulmonale with some ease. Because as we said, we always prefer to rule out the left-sided failure to define this category of right-sided failure called cor pulmonale. Now the important question is, what are the symptoms of cor pulmonale? You can think of it as symptoms of right-sided heart failure. Things like peripheral edema, ascites, hepatomegaly, jugular venous distension. Remember, how do we measure jugular venous distension? The normal jugular venous pressure is up to 8 centimeter water. Remember that sternal notch on patient who is inclined 45 degrees on bed is around 5 centimeter of water. And so if JVD's top pulsation is felt up to 3 centimeter vertical from the sternal angle, that is considered normal. But if it is seen higher than 3 centimeter vertical column measured from sternal angle, that's referred to as jugular venous distension. Now, an important finding in right ventricular failure and cor pulmonale is also presence of angina, especially exertional angina, and that is because increased oxygen demand. What are the ECG findings? We have the same ECG findings of pulmonary hypertension, such as right axis deviation and right ventricular hypertrophy, but we also have evidence for right bundle branch block and right atrial enlargement. Do you remember the specific criteria for right atrial enlargement on ECG? It is not surprisingly referred to as P pulmonale. And what is P pulmonale? It's a P with an amplitude greater than 2.5 millimeters in lead 2. Just a bridge to ECG assessment of chamber enlargement. Remember, P mitrale, or indication of left atrial enlargement, was a P wave in lead 2 that's wider, not taller, but wider than 2.5 small square or millimeters. Of course, the second criteria was presence of a significant negative deflection on the P wave in V1. But if you just stay with the 2.5 millimeter criteria, it will be easier to memorize. If it is taller than 2.5 millimeter in lead 2, it is P. pulmonale. If it is wider than 2.5 millimeter or 2.5 to 3 small square, that is P. mitrale. Now, what are the echo findings in support of cor pulmonale? Again, the echo findings that supports pulmonary hypertension, plus the echo findings indicating right ventricular dysfunction, and possibly the echo findings of tricuspid regurgitation. Please always remember possibility of secondary tricuspid regurgitation in right-sided heart failure. What is the best test for assessment of cor pulmonale? Similar to the best test for pulmonary hypertension, here is right ventricular catheterization. What do you expect to see? We could see again increased pulmonary arterial pressure. We would see decreased cardiac output, and we specifically see increased right ventricular filling pressure, also known as right ventricular end diastolic pressure. What is the management of cor pulmonale? The focus is treating the underlying lung disease. We can consider use of bronchodilators or oxygen therapy, as well as antibiotics if needed. We treat the underlying pulmonary hypertension, and we consider measurements for heart failure, including low sodium diet, and if needed, use of diuretics. What are the two major areas of difference in the management of cor pulmonale with that of left-sided heart failure? One is digoxin is of uncertain benefit in cor pulmonale, and there is increased risk of digoxin toxicity in patients with cor pulmonale. The other is diuretics use also requires caution. And why is it so? Remember, patients with cor pulmonale have underlying lung disease. Underlying lung disease means two things. One is adaptation of peripheral chemoreceptors of respiratory drive with lower than normal oxygen levels, and two, the major drive for breathing for the central respiratory centers being some mild levels of CO2 retention. Now, use of diuretics is associated with increased activity of renin-angiotensin-aldosterone system responsively, reactively, and this means a metabolic alkalosis. The body would compensate for metabolic alkalosis by blunting the respiratory drive or suppressing the sensitivity of the central centers to CO2 levels. This, in normal conditions, is the normal physiologic response to metabolic alkalosis. However, in patients with underlying lung disease whose main respiratory drive is CO2, blunting of that response could increase the risk of hypercapnic respiratory failure. It's not very common, but has been quite frequently reported in COPD patients receiving diuretics to warrant our caution. Now, I want to finish this episode with a case. We have a patient with exertional fatigue, dyspnea, and chest pain who also complains of increased weight in the recent months. And on physical exam, you hear a loud P2 and notice that liver span is palpable 2.5 centimeter under the rib cage. There is also bilateral ankle edema, and one of the legs seems significantly larger than the other one. What is the possible underlying etiology of his condition, and what is the treatment? We have a patient who has symptoms compatible with cor pulmonale because the patient has symptoms of right-sided failure plus the symptoms of pulmonary hypertension plus the symptoms of one important underlying etiology, and that is DVT, that raises the suspicion for chronic pulmonary embolism. Because of that, we need to order ventilation perfusion scan, and if the results come positive for chronic pulmonary embolism, the treatment would be surgical thrombectomy. However, if the patient is not a candidate for surgery, we can manage with thrombolytics or anticoagulation. And this finishes our discussion of pulmonary hypertension and cor pulmonale.